Hello, everyone. I'm PY Pangyun Cho, Chang Memorial Hospital. Good morning and good evening for my friend online with us. Thank you for your join. Especially today is our very valuable days because this is our 30 online webinar since last year and since the pandemic. And especially today, we are so happy and lucky to have Professor Yasushi Sugawara here with us. Professor Yasushi Sugawara has the MD and the PhD degrees. He is currently the visiting professor at the Department of Plastic Surgery at Jichi Medical University in Japan. Professor Sugawara is majoring in craniomaxillofacial surgery, including congenital cranial anomaly and hemifacial microsomia treatment. Besides, rhinoplasty and orthognathic surgery are his favorite. He was very popular and invited for numerous online international conferences to present his great achievement. Academically, Professor Sugawara is a productive surgeon in publications with almost hundreds of papers being published. Today, we are so honored to have Professor Sugawara here with us. The topic Professor will share is very interesting. The lift procedure in OGS patients. So let's welcome Professor Sugawara and thank you. Please, Professor Sugawara.
Thank you. Thank you, Dr. Cho. Kind introduction. And can you hear me?
Yes,
yes,
very clear.
And it's a great honor for me to be invited as a guest speaker of international webinar of Chang Hospital. And I would like to thank you, Dr. Cho, as a coordinator, and my old good friend, Professor Lo, and my mentor, Professor Yurei Chen, and many friends in Taiwan. And today, I'd like to talk about the soft tissue first approach in aesthetic orthognathic surgery, especially talk about the lip lift application for the OGS. Now, is it okay?
Yes, good.
Okay. Okay, first of all, skeletal analysis in orthognathic surgery is essential to obtain good functional and aesthetic result. But it's not so easy to get favorable aesthetic outcome because I think X-ray data does not include enough soft tissue information, especially in frontal picture. One of the good solutions is introduced by Dr. Yu, which is an intraoperative check of incisor show. They said that 2 to 3 millimeter incisor show is recommended. And I totally agree with the number. And I usually use this approach in my practice. For instance, this young lady had lip incompetence. And also she had the upper incisor show 8 millimeter incisor show. So I did maxillary impaction 6 millimeter. And now she got a very good incisor show 2 millimeter. And lip incompetence is improved as well. And also gummy show is improved and the patient has good lip and tooth balance in smile. Here's another case. She also had lip incompetence, and she has a -2 millimeter incisor show. So I did the maxillary elongation 4 millimeter. And now she got a 2 millimeter incisor show, and the lip incompetence is improved, and they have a good smile. So I would say that the 2 millimeter in lip upper incisor relationship is a golden standard number. And here's another case. One day, young lady visited me to treat her bimaxillary protrusion. In the cephalometry analysis, she's a good candidate of anterior segmental osteotomy, which is Wassman and Kelly. But if you look at lip incisor relationship, it is 2 millimeter. Yes, that is a golden standard number. So I have to say, I can't do the operation for you. But she came back a couple of months later. Doctor, I had a lip lift in another clinic. Now I got the shorter upper lip, so please do operation for me. Yes, surely her lip was shortened about 5 millimeter. I was so upset indeed at that time. There is no reason to refuse her request. So I performed anterior segmental osteotomy and genioplasty on her. Now she's so happy with this result. Then I wondering if lip lift could be a good solution for incisor show management. Then I started to check the historical background of the lip lift. First description of the lip lift is found in British Journal of Plastic Surgery in 1981. At that time, lip lift is introduced as one of the rejuvenation surgery. Procedure is quite simple. Only the skin is excised. The amount is vary from 1 to 6 millimeter in vertical height. Second one is found in PRS Journal in 1986. In that paper, 83 patients has performed with facial rejuvenation surgery. Design is also quite similar. And they described about the symptom of the periorbital aging like this. The aging lip has a lip drooping, less incisor show, thinner vermiform border, less pouting, convex contour of upper lip. And also, the authors introduced one patient talk in this paper. The patient said, the facelift is fine, and I like the eyelids, but the lip, I just love that. So the authors stressed the super effectiveness of lip lift in rejuvenation procedures. There are many good papers since then. I'd like to introduce some of them in my following talks. Basically, procedure is quite simple. I think the key issues are design and the amount of excision, but I'd like to talk about the anatomy first. Anatomy around the nasal base is a little bit complicated, which means that many tiny muscles come in together around the alar base. The one is the levator labii superior arachnoides and dilate anasi, depressor septinazi, and the ovicular oris. Now check the function. This sphincter function is by ovicular oris superioris. Here's multiformis plus orbicularis. And this is the function of direct energy. And this is the function of levator lavis superior arachnoid. Okay. And then now we will check the origin of these muscles. This is the approach to the LUFO1 osteotomy. Now I can check the muscle origin. This is, and then I separate the muscle. This is the depressor septinazi. This is the multiformis, the other side one. And the most lateral one is direct energy. Okay, check again the depressor septinazi that insert between the medial crus of the lower lateral LLC. And this is the multiformis that inserts around the nostril cell. Okay. The other side, the similar. Here you can see the insertion of the multiformis. The most lateral one is the direct energy and levator lavis superior arachnoid. Then I cut the unilateral side and completely release the muscle attachment. Now you see the ella base is loosened from the maxilla. It's kind of, the ella base is lifted from the maxilla. You can see the base view, the lateral side is lifted completely. So the muscle function, now you can understand the muscle function. And sensory at the branch of the infraorbital nerve. And the usually main tract run outside of the rib, and several minor branch run in the parasagittal area. And the design is like this. Basically, there are three types of design. The simple spindle type, and blue form. It's a blue form. And this kind of type. And they're divided, they're categorized in two types, in the shape, spindle or blue form. And nostril seal include or excluded. So what's the difference? The spindle and blue form. In the spindle type, the center portion is the most excited area. So lip vermilion border is lifted. In the center is the most. And the blue form is more laterally lifted. So in the simulation, you can see like this, like this. Other differences are scar. In this line, it tends to be visible in the frontal view, and also an upper and lower incisional line length discrepancy. There is a length discrepancy here. So that is the cause of dog ear around the area base. So some also recommended to do this kind of design. This design a little bit invisible because the upper line come into the nostril a little bit like this, and here's. And this blue form type is similar. And the incisional line is more longer than this simple one. So the discrepancy is less than previous design, okay? But you need to cut across the nostril seal here. So that might be disturb the natural nostril looking. Lafayette reported to 2013 introduced a way to preserve the nostril seal in this fashion. But personally, I have no experience of this approach. I think it's a very difficult procedures. So my personal design is a bullform type in shape and the nostril seal excluded. This is my personal way. And the amount of the skin excision is, I personally be equal to the amount of border, vermilion border lift. So if you want to lift the vermilion border 2 millimeter, I designed the 2 millimeter here. And the lateral side is excited 1 or 2 millimeter more than the central width, because I think this is the experience, not an opinion. I think it's better to get a good balance in the upper vermilion border. So again, if you want to lift the 4 millimeter without changing vermilion height, you can design 4 millimeter in the center width and a plus 1 millimeter more in the lateral size. This is my design. And I usually do mass rejection to lift lip margin here, stomium. Amount is usually 2 times of skin rejection. It depends on the case. Here's a 5 minutes video. This is the design. This is another nasolabial fold. Do not excess this line. Here I made a 4 millimeter excision line. And in the center, the 3 millimeter. This line along this, just below the nostril seal. Then I cut along the seal like this. And they usually use a bobby because it's a very easy to bleed. And first I excite the skin only, and then scratch like this. Then you find the mass fiber here's that here's a multiformis. Okay, now you have seen. Then I check the nerve, sensory nerve. You find the sensory nerve here. Yeah, you always find this kind of minor branch from here. The preservation is recommended. And here's the multiformis. This is the origin, okay? So I usually preserve this muscle and divided the auriculus oris from the multiformis and the dilators and the septi. And they excite the muscle about 2 times more, which is 6 millimeter at that time. The care must be taken not to harm the sensory nerve. And please look at the action. This putting the mass act the vermilion lip margin lift, but too much lifted give make the lip thinner. Okay. Again, skin lift margin or vermilion border. Mass lift the lip margin. The too much lifted make the lip thinner. The muscle lays fairly oral side, so that is the cause of this action. So then I checked where I should fix the muscle. Then I tried to find the insertion of the levator labii superior here. I check the muscle. Here the fibers of the levator labii superior, and then I put the 4-0 bicrete and place the stitch and check again. And the suture the orbicus oris to the levator labii superior margin. This is the first suture I do. Then I checked the lift level of the lip margin, and the second suture in the center. Put the stitch in the depressor septinaji and reconstruct the orbicus oris as it was. Now you can check the level of the lip margin. Okay. And I'll tell later, but the key to get a good result is this suture. I try to put this margin posterior, I mean the maxillary side as possible. Do not simply close the wound, but try to put deeply on the maxilla. That is a good, that is a very important point to get a good result in scar formation and also nasal form and the lip form. Here's a very three-dimensionally difficult shape, so this is a key point. Post-operative care, it's quite simple. I usually remove the stitch 5 to 7 post-operative day. I do not apply any taping post-operatively. I do not use Botox. And sometimes I do use steroid injection in the case of hypertrophic tendency patient. It's up to 3 times in months. I personally performed 73 cases. Out of 73 cases, 70 cases are combined with orthodontic surgery. Here I'd like to show you my cases. Here's a young lady. She visited me to have a treatment purely aesthetic reason. She said to me, please change my face, small baby face, by shortening mid-face. This is a common request recently. And in the skeletal analysis, she has a perfect proportion now. So I planned, her incisor showed the 2 millimeter, which is in contraindication of the orthoplastic surgery, but I answered her request. So I made a plan. Number 1 is OGS, maxillary impaction. Number 2, lip lift. The first, I do a maxillary impaction 4 millimeter. I did to do surgery and genioplasty like this. In the cephalometry, superimpose the upper incisor become -4 millimeter, and the menton become -8 millimeter. The skeletally, she got a very small skeleton. Now, upper incisor show become 2 millimeter to -2 millimeter. Then I do lip lift. Then upper incisor show change -2 millimeter to 2 millimeter. So here's pre and post OGS and post boost OGS and lip lift. Oblique view, breadth, OGS, post lip lift. In the lateral view, pre OGS, lip lift. Now you see a good balance in skeletal and soft tissue. Here's another case. This lady also complained about her long face. So I do a 2-jaw surgery and diagonal osteotomy on her. Now she got this kind of atmosphere. Then I do a lip lift on her, excite the muscle, and lift the vermilion border, as well as lip border and close. Now, before surgery, she has 3 millimeter incisor show, and after the maxillary impaction 5 millimeter, she got a -1 upper incisor show. Then I do a lip lift for her, and finally she got a 2 millimeter upper incisor show. And this young lady visits me to correct the post-operative redundant lip rings. Actually, this is a secondary OGS cases. She originally had a good soft tissue and the skeletal balance, but unfortunately, she had the 2-jaw surgery and a misdiagnosis in another clinic. So now her upper incisor show is -2 millimeter and less to show in smile. So I did lip lift on her, 4 millimeter in center, 5 millimeter lateral, and elevate the lip and suture. This is before and after. Now you see the good balance in tooth and soft tissue, and also a good smile. The last case is a very complete case. Excuse me. She's also a secondary OGS case. She has no upper incisor show, even in a smile. This is the X-ray. Unfortunately, her upper one lip margin discrepancy is almost 12 millimeters. This is a very miserable approach for the skeleton. Then I did maxillary elongation about 8 millimeter with bone graft. Of course, it will have slightly relapse around 2 millimeter indeed. So then I lifted the lip around 7 millimeter after that. Fortunately, she got a good smile and soft tissue skeletal balance. Now, the complications. Several complications are reported, but basically they are relatively minor. And the numbness will disappear around 6 months post-op usually. And the expression distortion is must, but after the 3 months, it will improve usually. And the scar is the biggest problem of this procedure, but basically precise approximation and general scar management is good enough. But sometimes you will have this kind of hypertrophic scar. In this situation, you have to apply some steroid injection or some conservative treatment. And over rejection should be avoided. This patient come to another hospital, and but unfortunately, I have no idea to improve this kind of deformity. And nasal deformity is another big issue. Common nasal change after lip lift are downshift of subnasal ella base, which increase the nursery show, and also slightly ella widening. Unfortunately, we cannot prevent nasal deformity, but I would say less amount is less deformity. And I previously mentioned my way to reduce nasal deformity is the way to close the lateral incision line here. Do not close directly to the ella base. Do not see this scar in the plane. Here's anteroposterior discrepancy. So do not close simply, but close to put posterior to the maxilla and then close this wound. So you don't need to compromise this dog ears and also get also avoid the nasal deformity. So in conclusion, lip lift is one of the good approach to obtain lip incision relationship. Careful planning is needed for aesthetically good outcome in OGS. So I'm so happy if my presentation was a nice present for you. Thank you for your time.
Thank you, Professor Sugawara. Very excellent and very impressive for the. I think it's a very bonus extra procedure after the orthodontic surgery, even in your 17 cases. Dr. Tu, Junior Tu will hand on for the Q&A section, please.
Thank you, Professor Sugawara, for your great presentation. I had a great time listening to it, and I learned a lot. Now, I have a few questions that I would like to ask you first. First of all, out of the 75 cases that you performed, you said that 17 were done concurrently with the orthodontic surgery. And the rest of the surgery, are they performed prior or do you perform them afterwards? And how long do you perform prior to the orthodontic surgery?
All the case is performed after the OGS because actual insider position could not be defined before the surgery, OGS surgery. So I always do the lip lift after the OGS.
But because the initial case that you showed us, the patient actually received the lip lifting surgery prior to the orthodontic surgery. So do you think that's a possibility as well, or?
Yeah, possible. Yeah, it has a possibility. Yeah, but in my case, I do. Yeah, I do after the OGS.
Okay, thank you. And also, Dr. Amit Basanavar would like to ask you, what type of sutures do you use for the procedure?
For the muscle application, I use Bicry, 40 Bicry. And in the dermal suture, I do the PDS, 50 PDS, and the 70 Pro-Ring for the coaptation of the skin.
And he also would like to ask you for the orthodontic surgery, do you use, what type of software analysis do you use?
Software, I do not use, I just analyze by the classical,
Okay.
yeah, classical cephalometric analysis. I don't use any 3D softwares.
And also he has one more question he wants to ask you, and it's about the scar management, because you mentioned that sometimes there might be some scars that you need to treat for the procedure. So is there any specific type of scar management that you would recommend?
No, I have no idea, because here it's very difficult to put any type of adhesion treatment. It's yeah, very, very difficult. So I try to lift, I try to avoid any stress to the skin. You know, I do many dermal stitch before coaptation of the skin. So that could be the one solution that I can do.
And also, Dr. Zhou would like to ask you, you showed one case where you harvest the bone graft to elongate 8 millimeters. Which part of the body did you harvest the bone graft?
I usually harvest from the mandible, the outer cortex of the mandible. We can harvest around the 1 by 2, yeah, 1 by 2 centimeter. If you obtain both sides, you will get more. But usually one side is enough.
Yeah, thank you.
And Dr. Kenwo would like to ask you, can the lip lifting procedure be done along with maxillary advancement procedure?
No, I don't. Yes, some doctors do the same time, but I personally have no experience. I think it's very difficult because incision is connected from inside and outside. So yeah, it's kind of a awful situation.
And he would like to follow up another question with how much time do you perform, like how long do you well actually, how much time do you have do you perform the lip lifting procedure after the OGS procedure?
I usually ask the patient to wait at least 1 month because the swelling is so yeah. I would like to wait the swelling settle down. So I ask the patient at least 1 month.
And Dr. Pogo Bonsi would like to ask you, what is the shortest white vermilion that you can leave?
It depends on the facial proportion, but basically 12 or 13, I guess. Because yeah, the length is very difficult because white lip, the film have a kind of curvature. So direct measurement is not the exact number of the upper lip. You know, it has a curvature like this. So I guess it depends on the curvature, but basically I preserve at least 12 and 13 millimeter.
And Dr. Pogobonsi would also like to ask you if you perform any corner lifts. And if you do, is there any tips that you can give us? And how do you prevent the Korean Joker smile?
I personally have no experience of the mass corner lifting. I would say I hate that one.
And Dr. Honda would like to ask you, is there any way that you can prevent over resection of the lift?
Yes, you should be no way, but I usually try to do, I usually not to excite too much, but actually I did do the lip lift on the patient, and maybe 3 or 4 patients I do again because the patient requests. So the too much is we can come back to the previous form once we excite too much. So the less is better.
And Dr. Zhou would like to ask you, would the nasolabial angle change after the lifting procedure?
Yes, that's a very good question. Yeah. Simple skin exercise always give a wide nasolabial angle formation. So I usually try to cut the muscle and bring up to the muscle to the around the anterior nasal spine. That prevents the nasolabial angle widening. Once you get nasolabial angle widening, it's very, very difficult to correct.
And Dr. Doobie would like to ask you if you use an internal lip lift, and when would you involve the nasal sill area?
I'm sorry, could you please?
Oh, he would like to ask you when would you do an internal lip lift, and whether you would involve the nasal sill area.
Internal lip lift, but I have no experience. Maybe I don't know from the inside or I'm sorry, I don't understand the procedure. Internal lip lift. Internal lip. Oh, yes.
Yeah, I'm not sure. Does it means the intraoral lift, lift?
I guess so. But yeah,
Yeah.
some doctor do. I know, but I think it's really difficult to control the level of the lip. I think so. And also the I've had that most of the cases have a sensory disturbance. Yeah, because the nerve run just above the mucosal layer. So internal approach is relatively difficult and risky approach.
Okay, I think Dr. Doobie followed up with like saying not intraoral, but
okay. Now involve, yeah. I personally do not like nostril involving. The reason is some patients have the very high nostril seal. Once we disturb the natural seal form, it's really difficult to reconstruct the nostril seal. Yeah, maybe you see the patient with the cleft lip and palate patients. That some patients have the good nostril, nice nostril on the healthy side, but cleft side had no nostril seal. That the difference is very visible, and I think the natural series, a very beautiful form. So I do not want to disturb that form. So I don't do that one.
And Dr. Reese would like to ask you, is there anything different that you would do for cleft lip patients regarding the lip lifting procedure?
Yeah, I do not introduce in this session, but I do the lip lifting in most of the revision cleft lip patient. But most of the patient with cleft lip has a very long lip, white lip, especially in the bilateral cases. So in those cases, I often do the lip procedure on the cleft lip patient, and also it's a good application. I sometimes do the uh, do the lateral only lip lift. I mean the center portion is connected, do not cut out. Then you will get we can steal somewhat of the white lip to the columella in the cleft patient. It's kind of a forked flap like. So I'd like to show those cases in in the future. It's a good application for the short columella cleft lip patient division.
And I'm sure it will be a great presentation too. And I'm sure everyone would love to hear it from you in the future, Dr. Professor Sugawara.
Thank you so much.
Yes.
And at this time, we would like to invite Professor Lun Zhongruo to give us a few comments.
Yes, Dr. Sugawara, it's nice to hear your talk. And I think this is a very helpful procedure when you wish to treat long lip or to increase the incisor show. I think first of all, I would like to comment about the scar. I think the external incision should be performed if you wish to shorten the lip to increase the
Hello. Oh my goodness, what's wrong with you?